So as we all know, there has been significant change in our understanding of CVJ over a period of time, and in past 2 decades, there is paradigm shift towards posterior reduction and posterior fixation, and C1 lateral mass screw. It has been demonstrated that that's a better construct and has biomechanically more stable as compared to other fixation techniques. So we know that vertebral artery injury happens to be almost 4.3% of time in craniovertebral junction surgeries, and occasionally it can lead to catastrophic consequences depending upon area of supply and collateral flow. And incidence of vertebral artery anomaly in the atlantoaxial surgeries region happens to be around 2.3%. And with a recent increase of availability of scans and wide applicability, it has been quoted to reach around 20%. So first, let's understand about brief anatomy of C1 and C2 and craniovertebral junction. C1 is a typical vertebra, and there is no body, and there are two lateral masses which are joined by anterior and posterior arc. So our area of interest here is the sulcus for vertebral artery. There we can see transverse process, transverse foramina, anterior arc, anterior tubercle, and posterior arc, and sulcus for vertebral artery. And this is inferior view of atlas. So axis is also a typical vertebra because there is a dense and its spinous process is quite large. And here we can see superior articular facet which articulate with C1, and a dense which is joins with C1, and this is we can see inferior articular facet. So these are some more views of C1 and C2, then superior point of view and inferior point of view. So now, classically, vertebral artery course, there are 4 divisions in vertebral artery. V1 after arising from subclavian artery till it enters in C6 foramina, and from C6 to C1 when it comes out of foramina, that is V2 part, and V3 from C1 till it's joined foramen magnum, and V4 is intradural part till it's become part of till it's joined opposite vertebral artery to become basilar artery. So here we can see this is our area of interest. This is normal anatomy. This is a B3 segment is coming. It's on superior process of posterior arc of C1. Here we can see vertebral artery. So this is normal course, and this brief anatomic depiction of normal course of vertebral artery. Vertebral artery reside here. This is our area of interest for putting a screw and C1 lateral mass. Here is our area of interest, and this is joint. We need to prepare joint. So first, we need to understand, as we have discussed already, there is chances of vertebral artery injury in around 2.3% of cases, and sometimes when it injure, it can lead to catastrophic consequences. But why we need to dissect an anomalous vertebral artery? Because we need to understand that dealing with C1, C2 joint is the most important part of CBJ fixation, because our main goal is to fuse, not fixation. As over a period of time, the strength of implant will come down and the strength of fusion will increase over a period of time. And C1 lateral mass is the better construct, biomechanically more stable, as it has been shown in various studies. It has been demonstrated in various studies. So now, this is we have described normal course of vertebral artery. So now let's come to anomalous part. So there can be various kind of anomalies, but representative anomalies are persistent first intersegmental artery and fenestrated vertebral artery. There may be anomalous origin of pica. There may be an high-riding vertebral artery, and there may be anomalies in occipitalized atlas. So what is it? Fenestrated vertebral artery? In fenestrated vertebral artery, one branch of vertebral artery passes caudally to C1 arc. If you can recall, this is the normal course of vertebral artery. This is the normal course, and here one branch passes below C1. Here our area of interest lies. Like we need to dissect. we need to prepare the joint and we need to put C1 lateral mass screw. So if we put a screw without cautious evaluation of vertebral artery here, then we will injure this branch of vertebral artery. Though sometimes this branch may be sacrificed, there is flow from other side, but it need to be identified and need to be coagulated and cut, and so that there is no catastrophic bleeding by pulling or snapping this part of vessels. So this is one case there where we can see significant atlantoaxial dislocation. Here we can see vertebral artery is this is C1 occipitalized atlas, and vertebral artery is passing right at our point of interest where we are going to put a screw. So if we do not identify this vessel, we may injure intraoperatively vertebral artery. So this is occipitalized atlas, and here C1 lateral mass, and this is C2. So we can see vertebral artery is passing just posterior to joint, and these are post-operative images where AD has been atlantoaxial dislocation has been reduced, and we can see bicortical purchase of C1 lateral mass screws. So this is one video representation after the patient is operated in prone position, and in standard midline is incision from anion to just below C2, and dissection in midline avascular pain, and subparietal dissection of over C2. And here we need to understand the basic anatomy. The vertebral artery lies almost always lies anterior to C2 nerve root ganglion. So here we are dissecting with combination of sharp and blunt dissection. We are dissecting posteriorly, and careful planes are being opened, and soft tissue is being incised. And frequent use of Doppler is very important. Frequent use of Doppler, we can identify the blood flow, and we can speculate like where vertebral artery exactly may be, and accordingly we can plan our dissections. So we are using frequently. We can see frequent use of Doppler is very important in these to avoid inadvertent injury to vertebral artery during dissection. So here C2 nerve root ganglion comes into picture, and C2 nerve root ganglion, cutting of C2 nerve root ganglion is very important, because after cutting it, it provides panoramic view of the surgical field, and vertebral artery just anterior to it. So see, this can be a combination of blunt and sharp dissection, as we can see here. C2 nerve root ganglion is being dissected, and it should be coagulated and sharply incised, as it being done here. So now we can see vertebral artery anterior to it, and so some soft tissue can be released. And this is our area. This joint is being prepared. Joint is cut sharply, and cortical surface is decorticated and denuded. And joint preparation is very, very important in these kind of surgeries. So it's denuded with the round work, and this posterior arc of C1 is being incised, so that we get some more space for putting the screw. And vertebral artery end has been mobilized inferiorly while putting C1 lateral mass screw. Here is our entry point for C1. So a screw has been put. This is being prepared on another side. A screw are being put, and we have put a screw on C1 lateral mass bilaterally. And we have to make sure that vertebral artery is not compromised at the after putting a screw head should be examined properly. So this is another interesting case where vertebral artery lies posterior to joint, and again this is occipitalized atlas. It's very not uncommon to find anomalous vertebral artery in occipitalized atlas. So here we can see it's lying just at the point where we are going to put a screw and we are going to dissect the joint. So this one surgical video, again after a standard midline incision, and the subparietal dissection. This is being dissected. Again, combination of sharp and blunt dissection. Frequent use of Doppler. These are very key steps in these kind of surgeries. So C2 nerve root ganglion, there are a lot of studies which say that C2 nerve root ganglion can be cut, it can be sacrificed, and we get a lot of space. And in particular, in case of anomalous vertebral artery, we have to cut C2 ganglion to get that panoramic view and that field and that vision. The C2 nerve root ganglion, it's identified and being transected sharply after coagulation. And there are venous plexus adjacent to C2 nerve root. So we need to take care of venous plexus also. The venous plexus need to be identified and need to be coagulated. This again, some soft tissue dissection is being done to mobilize vertebral artery, being incised sharply. Its vertebral artery is being mobilized. This is here our entry point will come for C1 lateral mass. Vertebral artery being mobilized inferiorly. And we need to understand while preparing joint, decorticating, denuding, and while drilling of C1, C2 facet joint, we need to mobilize vertebral artery superiorly. And while putting a screw, we need to mobilize, but C1 lateral mass screw, we need to mobilize vertebral artery inferiorly. Joint is being prepared here with the blunt and dissector is the joint is open now. You can see it's decorticated and denuded by using drill. So same principles are being followed on opposite side. Same principles are being followed on opposite side and frequent use of Doppler. And here we are dissecting, and here again C2 nerve roots coming to view, and nerve root is being identified and being cut, transected sharply after coagulation. So we can see this after transecting C2 nerve root, we get a beautiful view, panoramic view of vertebral artery and anterior structures. So here we can see vertebral artery, and this is our area of interest. Joint has been prepared, and after that C1 lateral mass and screws were put. And we use autologous graft from rib or like a spine for fusion. So this is one another interesting case where we are mobilizing vertebral artery. Here C2 nerve roots come into view. So C2 ganglion, its position of vertebral artery is being checked with the frequent use of Doppler. This we can see this is quite big, and in this case C2 ganglion. We are confirming position of vertebral artery with the use of Doppler, and C2 ganglion is being dissected. It's being dissected with blunt hook and scissor, and anterior vertebral artery lies just anterior to C2 ganglion. Soft tissue structures is after coagulation, it's being transected sharply, and other structures are. So here we can see vertebral artery after transecting C2 ganglion, and here after area of interest of putting C1 lateral mass screw. So we can. So sometimes we need not to mobilize vertebral artery right from foramina, because if we can get enough space, because most of the time these are ectatic and serpiginous and abnormal anomalous vessels. So most of the time there is enough length for mobilization available. So this is a screw point, entry point is being made for C1 lateral mass screw in this case. So these are some cases. This one case where there was fenestrated vertebral artery, and we can see odontoid with atlantoaxial dislocation. Vertebral artery was dissected and a screw was put in C1 and C2. We can see postoperative X-ray here. There was huge, significant, in MRI you can see here, there was significant atlantoaxial dislocation and cord changes also. This patient presented with quadriparesis, and postoperatively patient improved. So this is one intraoperative view where we can see images after C2 ganglion has been cut, and we can see image of vertebral artery right anterior to it. And this is C1, and down is C2 spinous process. This is one another interesting case where we can see this is CT angio images, and there is hardly any space for cord. We can very well we can appreciate hardly any space to cord. This patient also presented with quadriparesis, and vertebral artery where we can see lies inferior to occipitalized atlas in this case. So in this case, I could not put a screw in C1 because it was very difficult. I was not getting any space in that, and in this case, occipital and C2 fixation was done, and postoperatively patient improved. Here we can see postoperative images. EAD and visceral invagination has come down significantly. This one another interesting case where you can see significant compression over cord. We can appreciate here in T2 weighted sagittal images, and this is volume rendering and reconstructed CT images of CT angiogram. And this, I would like to specifically, I would like to mention cautious evaluation, preoperatively cautious evaluation of 3D VRT images is very helpful in planning and understanding of anomalous vertebral artery course. And as a protocol, we do preoperative CT angiogram for all craniovertebral junction fixation cases. So here we can see postoperative images. This compression has come down significantly. In this case, also vertebral artery just inferior to C1, just inferior to C1, and right where we are going to put our screw. If we do not do CT angiogram, we will not know. So first is I would like to mention, first important step in preventing anomalous vertebral artery injury is to identify first. Preoperatively, we do angiogram, we do cautious evaluation, we will come to know the course of anomalous vertebral artery, and that can be avoided by careful intraoperative and preoperative planning. This inadvertent injury to vertebral artery can be avoided. So this same case, intraoperative X-ray. This one another case where we can see this C1 and C2 fixation was done after dissecting vertebral artery. One other interesting case where we can see significant compression with the orthodontoid, and these are postoperative images where the compression has come down and AD has come down significantly. This is one another interesting case, one patient who presented with the quadriparesis. Here we can see significant, this cord is very thin here. You can appreciate, cord is very thin and there are a lot of signal changes and the significant atlantoaxial dislocation. And we can appreciate vertebral, again, occipitalized atlas and vertebral artery is below C1. And bilaterally it's below C1. Here we can appreciate joint, and this side is it's dominant, and this side is non-dominant. And I would like to mention we should explore first on non-dominant side. If vertebral artery bilaterally there is anomalous course, we should explore on non-dominant side first. So these are images, CT scan. We can see atlantoaxial dislocation and basilar invagination. These are postoperative images where atlantoaxial dislocation and basilar invagination has been corrected by. So that's why dealing with joint is very important. Even if sometimes we may not be able, as we have seen earlier, sometimes we may not be able to put a screw in C1, but dealing with C1 joint manipulation and preparing of C1, C2 facet joint is very important. It helps in reduction and manipulation of joint. So here we can see post-operative images. There has been AD and visceral invagination has been corrected. So this is the view that we get. This is C2 nerve root that has been transected. This is vertebral artery. Here, this is C1 lateral mass, and this is C1, and this is C2. And one more important point: after putting screw head after putting C1 lateral mass, screw head should be examined properly. We need to make sure that it's not compressing the vertebral artery. So here we can see there is a lot of space available, and it's being checked with the ball dissector also. So here we can see vertebral artery is visualized, and C1 lateral mass screw has been put. And same as on another side, we have put a screw, it has been examined, the screw head has been examined, it has been made sure that it's not compressing the vertebral artery. So what is the take-home message? So as our understanding has increased over a period of past 2 decades, and there is shift toward posterior screw fixation, C1 lateral mass fixation, and C1, C2 fixation. And C1 lateral mass screw is considered a superior construct because it's biomechanically superior as compared to other techniques. And for all cases, craniovertebral junction fixation cases, CT angiogram should be done, and there should be cautious evaluation of course of vertebral artery. As we have discussed, vertebral artery anomaly is associated almost 2.3% of time, and vertebral artery injury sometimes can be very catastrophic in these kind of cases. And vertebral artery should no longer be identified as a hindrance to approach the atlantoaxial joint. And preoperative 3D CT angiogram and volume rendering images, morphometric assessment of vertebral artery for its size, for its anatomical course and relationship to the adjacent bony landmark at the craniovertebral junction is very crucial, and it should be identified. And identifying the anatomy and the variations of the vertebral artery and C1 vertebra is necessary in the choice and plan of surgery, and it raises the accuracy and safety of precautions. Thank you. Thank you very much. So, any question, please?